Good morning. It's a pleasure to be here with you again at the Ministry of Health's virtual media conference to bring you up to date on the ministry's COVID-19 response. Providing us with current information today are the Honorable Terrence Deyalsingh, Minister of Health, Dr. Avery Hines, Technical Director of the Epidemiology Division at the Ministry of Health, and Dr. Antony Parkinson, Technical Director, Hospital Services. I am Candice Alcantara, your moderator and Manager of Corporate Communications at the Ministry of Health. The Honorable Terrence Deyalsingh will now present the opening remarks.
Thank you, Candice, and good morning. Good morning to Dr. Hines. Good morning to Dr. Parkinson. Ladies and gentlemen of the media and the listening and viewing public on this rainy Saturday morning, Saturday the 19th of September. I hope wherever you are safe and dry. This morning, as we bring you the latest global information and local information, we are going to be contextualizing where we are locally and telling you what the facts and figures are, what the trends are, where we are, but we must contextualize it as what is happening globally. Last week, Saturday, at the Diplomatic Center, we would have indicated at that time that we expected the world to hit the unenviable mark of 30 million cases. We have, in fact, reached that. It is an unenviable target as a global community. We are now at 30,767,440 cases. So the global pandemic is showing no signs of slowing down, as opposed to maybe what is happening in Trinidad and Tobago, which Dr. Hines will talk about. Unfortunately, 957,608 persons around the world have died. And we'll be talking about a million deaths sometime in the future. Ladies and gentlemen, I know that locally, regionally, and globally, persons are anxious to get back to their normal lives. The adaptation to the new normal is a difficult one for us locally and around the world. Persons want to get back to their social lives, to how they used to live and interact with people before COVID. But as we keep talking about the new normal, it is just not possible at this time. So the messaging remains the same, regardless of how monotonous it may sound. But this morning, I just want to change not the message, but the way the message is being communicated from these platforms. And I'm going to ask that a clip be played. This is Dr. Maria Van Kerkhoff, the WHO COVID technical lead. I want us, it's a very short clip. She is giving us some basic messages, same things that we have been saying. But I am hoping that a different messenger, maybe saying the same things differently, may resonate with Trinidad and Tobago. So may we have the clip, please, and then afterwards we'll dissect it.
Everyone on the planet needs to know what role they have to play and to be informed about what this virus is, where this virus is circulating, especially in the areas where you live, the areas where you work, the areas that you want to travel in. All of this is important. There's so much that you can do yourself to protect yourself from getting infected and to prevent yourself from passing the virus on to others. And please make good choices. I know that there are a lot of things that we want to be doing right now, but there aren't necessarily a lot of things that we need to be doing right now. There are many people, essential workers, who cannot stay at home. There are many people who are caring for patients in hospitals who cannot stay at home. And if you can, and if you can help, and if you are asked to, please stay home. You can practice physical distancing from others. You can avoid crowded places. You can avoid enclosed settings that have poor ventilation. You can clean your hands. You can practice respiratory etiquette. You can wear a mask if you cannot do physical distancing. Everyone has a role to play. And this is far from over. So we all have to play our part.
Thank you very much. Very short video, But I think the messages are important. What are the 5 major messages? 1, the importance of individual choices. All of us need to make the best individual choice. She said we may want to do certain things, but we may not need to do certain things. Dr. Alana Kwamana-Best was here this week, Wednesday, and she shared the example she has in Sangre Grande, where an elderly man, his family, who loved him to bits, hosted a birthday party for him. And out of that came 2 positive cases. Now, it's a good thing he wasn't infected and that he didn't have comorbidities. He could have been an unfortunate statistic. She also spoke about the case where one person knowingly went to work ill and infected 45 others. So that is a message Dr. Van Kerkhoff gave when she said we may want to do certain things, but we don't need to do them. Dr. Van Kerkhoff also spoke about let's consider the perspective of healthcare workers. Last week, Sunday, I was at Cuba. Yesterday, I toured both Cora and Arima. So in the past week, I've been to the 3 major facilities taking care of COVID patients. And again, healthcare workers are the backbone of this response. But we don't want to overburden them. And as the goodly doctor said, healthcare workers don't have a choice. They have to go out to work. But many of us have choices about going to work ill and going to that gentleman's birthday party. So she spoke about good choices. And I think the last message we could take from Dr. Van Kerkhoff is that this thing is far from over. The virus, as we see now, 30 million plus cases. The average number of cases per day continues to be around 300,000 globally. Pay attention to what is happening in Europe. Many parts of Europe are going into a second stage of severe lockdown. We are not there. Prime Minister Boris Johnson is considering what measures he's going to implement, and he's considering those measures this weekend. So, ladies and gentlemen, the message coming from this platform via Dr. Maria Van Kerkhoff is a simple one. Until we have a magic bullet, the magic bullet that we do have are the public health measures. Wearing your mask, physical distancing, stay home if you are ill, avoid the unnecessary congregation, don't invite people to your homes. If you are celebrating a birthday, celebrate it with your immediate family. Don't invite people in, keep your friends and so on out. And let's just do this together, and we will continue on the path that hopefully Dr. Hines is going to talk about. Thank you very much for your kind attention over the past few minutes.
Thank you very much, Minister Deyalsingh. And we move now to Dr. Hines, who will provide both the clinical and the epidemiological update this morning.
Thank you, Ms. Alcantara. Good morning to the Honourable Minister, to my colleague Dr. Parkinson, to the members of the media and members of the listening and viewing public. The clinical update for this morning is as follows. For the morning update of Saturday, September 19th, we are currently at 28,774 tests or samples having been submitted to CARPHA, UE, and the other local sites for testing for COVID-19. Of those, 25,711 would represent unique tests completed, and there would be 3,063 repeated tests within the larger number. The number of samples which have tested positive stands at 3,739. And we are currently at 1,984 active cases. You would see that the active cases will now begin to actually come down as the period for self-isolation in the households as monitored by the CMOS-H. That 3-week period is now beginning to come to an end for some of the more recently diagnosed individuals, so you will see that number starting to decrease. The number of deaths stands at 60, and again, we extend our condolences to the bereaved families. Number of persons discharged from the public health facilities stands at 829, and the recovered community cases, those are the ones I just described, those stand at 866. Since our last update, you would note that 88 additional persons would have been added to the list of positives, but these persons represent tests that would have been from samples collected between the 10th of September and the 18th of September. Therefore, the increment doesn't represent a single 24-hour period. These 88 individuals will now be processed individually. The clinical status will be assessed, and they will be processed for either admission or monitoring in home isolation as dictated by the public health and clinical professionals. 7 persons since the last update would have been discharged from public health facilities, and the individuals currently in our institutions in the parallel healthcare system stand as follows. We have 86 hospitalized patients, 50 of whom are at the Hoover Hospital and Multi-Training Facility, and of those 50, 4 are in the ICU and 7 are in HDU. We have 25 at the Cora Hospital and 11 at the Arima General. And the patients in step-down facilities currently stand at 131, with 7 in UEDB, 52 in UE Canada Hall, 72 in UE Freedom Hall, the other institutions at this time remaining vacant. That brings me to the end of the clinical component of the update. I would now like to switch directly into the epidemiological component. We have some slides. So, epidemiological update for Saturday, 19th September 2020. Next slide. First, we'll show the epidemic curve, which gives a better idea of number of positives occurring on a given day as we separate these by the actual date of collection. What we do see is that the trend in the darker blue bars, which is the color that we've chosen for the current month, the month of September, appears to be going down. Now, we do know that as we do the updates, sometimes figures get revised retrospectively, as we noted that some of the tests would have been from a period before today's update. But even with that recurring pattern, which is in itself diminishing, we do see that there's a tendency to see fewer new cases on a daily basis within the month of September. There are a few other interesting things on the graph that we want to point out. We have a few arrows at different dates. We have the date of the end of July when we began to look at rolling back some of the freedoms, the numbers of individuals gathering to less than 10, things that we noted were necessary as we began to see an increase in the numbers of cases on a daily basis. This was early on, and even so, we do note that the recommendations to reduce gatherings and to reduce congregations above numbers of 10, that those recommendations weren't necessarily followed in the first week or so of August. We do see that post the recommendation on the 17th that we have no in-house dining, no gathering at beaches, etc., that there continued to be something of an uptick, and that on the 2nd of September, which was approximately 2 weeks after the quote-unquote last lap activity that preceded the closure of beaches and bars, that we did have a spike that most likely corresponds to an increased number of individuals coming into contact and therefore transmitting illness. But since that, we've seen that downward trend, and we're hoping that that trend is continued. We do know the last point on that graph is the 31st of August, where the mask legislation came in, and we're hoping that it has the continued effect of reducing risk of transmission on a daily basis. Next slide. We're going to look at the demographics, both age and sex distribution. So for the positive cases, this is all diagnosed cases going back to the first one, we see that the pattern remains essentially the same, where those between 25 and 49 comprise nearly 60%, 57% of the total number of positives. And we have 16.9% in the under 25s, and the 50 to 59 and 60 plus are 13.9 and 12.2 respectively. The balance of male to female is still predominantly male, a little over 53% men and 46% women. Next slide. But the pattern among those who have passed on is a little different. There is a greater predominance of men, again over 83% of the people who have passed on were male, as opposed to a little over 16% of those who were female. The under 50 age group overall is only 13% of the total number of deaths, and there are no women in that under 50 age group. The total in the 50 to 59 age group is 16%, 16.6, and in the 60 to 69 age group, we see that that increases. So the increased age factor does represent itself in the proportions of individuals in these age groups who have passed on. Next slide. The geographic distribution, we're just giving you the updates. Continue. As we've seen before, this is all three phases. Next slide. This is just phase 2, showing the repatriation and the local cases, repatriations in purple or pink, depending on how it shows up on your screen, and the phase 2 local cases being seen in blue. Next slide. And this is just the local cases. Now, what we do see in the third slide, sorry, next slide, is that the distribution of cases in places where we had not initially been seeing large numbers, that distribution is beginning to increase. We are beginning to see more cases in the areas to the east of Trinidad where we had not initially been seeing cases, and this, as we indicated before, is simply because the virus follows movement and behavior of people, and wherever there are people, there will be virus. But we do want to point out that there is that trend that we are noting, and to advise everyone across the country to continue to adhere and to improve adherence with those public health measures of physical distancing, of hand hygiene, of avoiding gatherings, of avoiding going to work when you are ill, because this is really the only way we're going to apply a braking force to that rate of transmission that we're seeing from person to person. And that brings me basically to the recent set of comparisons that we have added to this epidemiologic update, and that is looking at background mortality. So on the left, in the yellow, we see what we showed the last time, that the basic numbers, the average numbers of cases of deaths with pneumonia-related causes has not really surpassed the average for the previous 3 years. So our 2020, January to August figures are in the yellow bars, and that red line represents the average over the past 3 years. And on the right, as previously requested, what we're seeing is all-cause mortality, 2020 being the gray bars and the red line being the previous 3 years. This is deaths from all causes. And again, we're just about on par with the previous year's occurrences. And this reflects two things. One of them is that background activity that we may not be picking up in our health system and with our surveillance, has not really changed or begun to exceed the expected mortality with regard to the normal baseline rates of death, because every year people will die from pneumonias, every year people will die from something. And those deaths, that death rate has not begun to change. We're hoping that we can maintain that, and part of that is because we do have some measure of success in maintaining the health care provided to the population across the board. So that ends my slides.
That is my slide.
Okay, this is the minister's slide, again pointing out the importance of not being the one person that's at the head of the pyramid and increasing the risk of transmission to other individuals. And I'll turn you back to Ms. Alcantara.
Thank you very much, Dr. Hines. Dr. Parkinson will now present on the topic of COVID-19 ICU management.
Good morning, Minister Deyalsingh, my colleague, Dr. Avery Hines, Ms. Candace Alcantara, and to you, Trinidad and Tobago. Right, I'm going to not going to be as detailed as my colleague, Dr. Hines. We in intensive care are not very much, what shall we say, acquainted with a lot of graphs and mathematics and all this stuff. We go straight to the, I won't say the jugular, but I think you know what I mean. Now, so far, with the data we have at hand, we have seen a certain pattern emerging in that hypertension and diabetes seem to be the, as it were, the #1 comorbidities that seem to be very common among patients who succumb to the COVID-19 virus in the ICUs. We followed closely by chronic kidney disease. People who have kidney disease, some are on dialysis, some just have bad kidneys that are borderline. They can live with it, but when you get the disease, when you get the COVID virus, you, as it were, being pushed over the edge. Cardiac diseases, about 18% of cases have been shown to have cardiac diseases. Cancer, yes, 10% of people who have died have had some history of ongoing cancer. There is something we're not seeing so much in Trinidad, probably because our population is not as large as America, is obesity. A body mass index of 30 increases your chances of dying as one of the comorbidities if you end up in ICU. Alcohol consumption and smokers, yes, they do reach ICU as well, but these are long-standing cases who have been smoking all their lives. Now, as Dr. Hines has shown, the people who succumb to COVID are the elderly populations. We have from 65 and over seems to be the increase in the number of, or shall I say, the chance of succumbing to COVID. The average age of males and females who succumb to COVID in the ICU is about 65% actually. But we do see an interesting phenomenon which we cannot explain yet, and that is we have a male to female ratio of 5:1. Why is it there are so many more males infected and succumbing than females? We are still looking to find out why exactly is that happening. Remember, most of our population who are dying from this are those who have multiple comorbidities and also have increasing age. But I'm talking too much about mortality. I'm talking too much about how many people are dying. We have success stories. When you go to ICU in Couva or in Arima or in Augustus Long, it's not a death sentence. People are coming out alive. When I was in the COVID unit, as it were, in Couva Friday, I came upon a patient there. A patient is 70-year-old male with CABG, meaning that he had bypass heart surgery earlier in the year. He also has diabetes and hypertension. So he has all the factors that make it, what shall we say, stack against him to make it unlikely that he will survive. On top of that, he also had to go to ICU twice. They thought he was getting better, took out the tube, remember the tube we talked about, in his going to his lungs. They extubated him, and then he deteriorated, and then they intubate him again. If you're in ICU, working long in ICU, you realize when you have to intubate a person a second time, mortality skyrockets. But this elderly gentleman survived. He survived to the point now he is on the ward, on the lowest amount of oxygen right now. Talk to him, he could talk to me. We had a nice conversation, and he gives God the glory that he has survived to this point. We are hoping to see him back out in the community pretty soon. That is one of the, what shall I say, the high points in ICU. We see a fair amount of mortality, but we do see people surviving, even people surviving against the odds. Now, that's a good point. I just want to keep a warning. I saw at least one patient as young as 34 years who succumbed in ICU. And you know what? He had no comorbidities. So he's young, no comorbidities. That means he has a good chance of surviving, yet he didn't. It means that, young people, you are not immune to this disease. I know it's a small chance that you could die from it, but you are not immune. Do not play Russian roulette with this disease. We understand it's inconvenient, but please, wear your mask when you're in the presence of others. cut down the congregation of people together. Let's reduce the chance of you getting this disease. We don't want to overflow the ICU. ICUs are very manageable at this point in time. I have to be careful how I say that. My colleagues in ICU are very superstitious. Anytime I mention something about, oh, we're doing well, we have few patients. Next hour, we have a barrage of patients coming in. I know my colleagues who hear me now are collectively knocking on wood, as I have said this thing. Other than that, we have learned as well that if you have greater than 3 comorbidity factors, such as diabetes, hypertension, cardiac problems, and you add it up, your chances of survival diminish quite a lot. We've seen that. The less comorbidities, the younger you are, the fitter you are, it seems that you have less chance of succumbing to this disease. So my final word today, at least for ICU as well, we beg you, we implore you, please do not become a statistics. We don't want to see you in ICU. We don't want to have to take care of you in ICU. Please abide by the wearing of mask. Some of you are saying that masks make you uncomfortable. Masks makes you make it difficult to breathe. An asthmatic from where I work came to me asking if she could get an exemption from wearing a mask. So I talked to her, and what we discovered is, yes, you're an asthmatic. You have a high chance, you have a chance as well, increased chance of succumbing to COVID as well. That's one of the risk factors too. However, if you wear a mask, you reduce the chances of getting infected. So still wear the mask. Yes, it will impede your breathing if you go into an asthmatic attack. When you're going into asthmatic attack, you breathe very quickly. A mask cannot allow you to breathe very quickly. Those of you who exercise, some of us do exercise, when you are panting, you realize the mask gets in your way and the mask almost stifles you. But in normal working conditions, a mask does not stifle you. You take your time, you move around the place, wear the mask if you're asthmatic, cut down the chances of you getting the infection in the first place. Don't sacrifice comfort. Don't sacrifice comfort. Or else you will, that's the wrong way to say it. Don't sacrifice convenience or put convenience above your ability to get the mask, the chance for you to get the COVID-19 disease. So I think I will not bore you with anything further. Hand you over to Candice. Thank you.
Thank you very much, Dr. Parkinson. And we move to the question and answer segment. To our media representatives, please state your name and your media house, and we request a maximum of 2 questions, please. We begin with CL Communications.
Good morning. I just wanted to find out, the union representing TNTech workers, they claim that they are getting 2 sets of rules for quarantine. They say that the CMO office is giving the rule that the primary contacts at TNTech should go into quarantine, while the other health ministry professionals is giving another set of instructions for quarantine. I was just wondering if the Ministry of Health was aware of this, and has the ministry met with the TNTech to determine a COVID-19 workplace strategy? My second question was put to me, and I was just wondering, it would be prudent to put it to the conference. If a swimming instructor has 1 student at a time in the pool, while the instructor is outside of the pool conducting the class with just 1 student, is this allowed, or is this a contravention of the Ministry of Health guidelines? Thank you.
Thank you very much.
Okay, thank you for the questions. The first, I'll relate to the difference or the potential differences in instructions. Once there is a primary contact of a confirmed case, the procedure is that primary contacts of confirmed cases are expected to be quarantined. I'm not sure if there's any miscommunication at any individual level, but the national policy does indicate that quite clearly. We have, and we can again, we have had interactions with bodies like TNTech and other agencies that need to ensure that they maintain the functionality of their crews, the functionality of their staff, even as they attempt to abide by the rules. And if there's a need for any additional consultation or clarification, that is again welcomed. That those requests can be sent into the ministry, and we can clarify anything that is currently unclear. With regard to the second question, the current regulations indicate that there is to be no activity in pools and the like, and that means that anything, no matter how you attempt to modify the risk factor, the gatherings in these settings are currently discouraged. And so we'd like to maintain uniformity across the board, across the population, in not trying to deviate from or find exceptions to the general rule that we're discouraging this kind of activity at this point in time. Ms. Alcantara.
Thank you very much, Dr. Hines. And we move next to AZP News, please.
Hi, good morning, Priya Bihari, AZPnews.com. Doctor, just to follow up on Natalie's question, I don't think you answered it about non-contact sport. I think yesterday you issued new guidelines, and you said that people can take part in non-contact sports. People just want to know if you can list what are the non-contact sports and what are not. Just for clarification. And the other question to the minister, there has been a lot of number of calls to have the public health regulations debated in Parliament. I don't know if you have any thoughts of that or if that's going to take place. Thank you.
Okay, so thank you, Priya, for the question. Yeah, so we did say contact sports, contact team sports, football, cricket, basketball, netball, so on. We want to discourage that, and I think the regulations speak to that. We did make some exceptions because people were asking us. For example, the president of the Tennis Association, that is not table tennis, lawn tennis association, he met with me on Tuesday, and he asked me to clarify the position on things like lawn tennis and so on, where those clubs could stay open, for instance, in Nelson Mandela Park and so on. So we did do that clarification. The other question, no, regulations have never, okay, let me be careful. The regulations are made pursuant to parent law, the public health ordinance. Regulations are not meant to be debated in Parliament because in a pandemic, you have to act swiftly. That is why the regulations don't talk about being in your private space. That has to be debated in Parliament. But these regulations where we have to move swiftly, and Justice Budu Singh spoke to this. He agreed that regulations have to be formulated and implemented swiftly to protect lives, to protect livelihoods, and to protect the public interest. But anything that needs to be debated, like the mask legislation, will be debated. Thank you very much, Priya.
Thank you very much, Minister. And now 98.1, please. Okay, I think we're not hearing Mr. Cummings, I think it is, from 98.1. We seem not to be hearing you.
Hello?
Okay,
yes.
Great. We hear
Lovely.
you now. Thank you.
Yes, all right. Good morning again to the
morning. Good
panel.
morning.
Stephen Cummings, 98.1 FM. My two questions for the Minister of Health. You may have a rather heavy load this morning.
Right.
Minister, we have moved from imported to sporadic to cluster and now to community spread. And the aim now is to move us back to cluster, in as short a time as possible. One of the key strategies, though, in treating with the virus is to have a seamless fusion of political solidarity. Are you satisfied with the level of political support from the opposition and your opposition MPs in beating the virus? Quite often, we hear comments and statements that are in complete variance to the messaging of the ministry, and we're not just talking about the anti-vaxxers. And secondly, an elderly high-risk heart patient wrote to me on 2 occasions saying he is constantly turned away when he goes to the Mount Hope Pharmacy Clinic to access heart medication. Deflon, rivaroxaban, and a host of other drugs are said to be constantly not available. As far as you know, is there any shortage in supply or in the supply chain at Mount Hope, resulting in persons possibly not being able to access critical drugs for treating chronic heart conditions?
So thank you. So let's take the second question first. I am not aware of that, but we are willing to assist. If you send that person's name and phone number to Candace Alcantara, we will surely get in touch and unearth the facts and try to assist them. Two, you asked me about opposition support. I don't think I want to get into a political to and fro with the opposition this morning. That is not useful. What is more useful is for all of us, as I keep saying, to abide by the spirit of the regulations. What we are asking people to do in public with gatherings and masks and so on, we are asking people to do in private. The opposition's track record and statements are well known, starting from implement a state of emergency, lime and puncheon, all those things are well known. It is not useful for me to engage in a fight with the opposition on this platform. The only fight I want to engage in is a fight with the virus. And all of us, all 1.399 million, have to be soldiers in this fight against the virus. Let's all work together to keep the virus at bay. Notice I'm not saying defeat the virus. We have to keep the virus at bay. If we could get that type of solidarity, we will come a long, long way. Thank you very much.
Thank you very much, Minister. And now questions from Guardian Media Limited.
Hi, good morning. My name is Sweeney Gray from CNC3. I have two questions. I believe the first question might be for Dr. Parkinson. Of the adults who are not elderly with no comorbidities, what typically has been the cause of death? And my second is either possibly for Dr. Hines and or Dr. Parkinson. I wanted to ask about long COVID. Have you been experiencing patients lately or finding patients locally who have been experiencing acute long COVID symptoms, and how has that actually manifested in patients in Trinidad and Tobago? Thank you.
Thank you for that question. Well, the first one, we don't have many elderly people with no comorbidities, but because I mentioned that there are a few patients with no known comorbidities, when they arrive at the ICU, they have no known comorbidities. However, sometimes you find out that their blood pressure is elevated or their sugar is elevated, and they may have the beginnings of these comorbidities. However, to answer your question, the common pathway it seems that that patients die or suffer from is something called adult respiratory distress syndrome, where the lungs itself, because they become so inflamed because of the virus, they fill up with fluids. And the fluid prevents the oxygen from passing from inside the alveoli, the air sacs in your lung, into the bloodstream. They prevent that. And it's as if you are suffocating. That's why you need to be on so much oxygen. And when you reach the ICU, it's not just 100% oxygen you might be getting. You've got to get oxygen under pressure, which you cannot get under the normal atmosphere. So they do die because of this pneumonia, this inflammation that takes up the whole lungs. A second thing that's coming up very often now, and I'm glad you answered that, but is acute kidney injury. Now, they may come on board into the ICU with nothing wrong with their kidneys, but the virus seems to have an effect on the kidney as well. There are many factors that affect the kidneys, but one of the factors is the inflammation also reaches the kidneys. Other factors are the lack of oxygen. The patient goes into shock because of the infection in the lung. It causes the patient to go into what they call septic shock, and the blood pressure drops precipitously. Patient has to be on medications that are given via the intravenous route that has to be given continuously to keep the blood pressure up. If the blood pressure goes down too low, it damages the heart muscles and the kidneys itself. In fact, urine output, the amount of urine output somebody gives out in the ICU, gives us an idea how well the kidney is functioning, and also give you an idea how well the other organs are functioning, because we are seeing the function of the kidney by giving in its ability to give out urine. So the two major causes of death in ICU are the ARDS, adult respiratory distress syndrome, the lung inflammation, and two, there seems to be a rising trend of acute kidney injury as well in the ICU. The second question was concerning, could you remind me the second question?
It was regard to long COVID, long symptoms.
Okay, well, how can I answer that? Something I left out, and I want to bring it up, a very pertinent point is we have a few patients who are deteriorating at home because they're at home, they are quarantined, they have a little bit of shortness of breath, and they feel well. They can move around the house a bit, but it's a little harder. The inflammation is taking place. The virus is there and it's causing this fluid to be overloaded, but it also reduces your ability to fight other infections, and you also get other bacteria, mostly from your mouth, upper respiratory tract, that actually comes and invades your lungs. So you get two infections. You get a virus there causing its own trouble, and then you get a bacteria, right? What they call community acquired pneumonia. That now makes life complicated in the lungs. You get difficulty breathing. Difficulty breathing meaning that you may be great at rest, sitting down and relaxing, you go okay, your heart rate is good. The moment you get up to go, as it were, to walk to the toilet, just to the bathroom, you find yourself out of breath. You find yourself gasping for air. At that point in time, you shouldn't reach that point in time, but at that point in time, you need to be in a hospital. You need to call GMRTT, 811, call them. They will take you straight to a COVID hospital. People have died at home, and people have died on the way to hospital or at hospital as soon as they arrive at the hospital because they stayed too long at home. So what the doctors are on the, in the community are doing, they're calling patients and they're asking specific questions. They want to find out if you have any further infections, like you're feeling like you have fever, you're feeling weak, tired. They're asking about how you're breathing. Are you having difficulty breathing? Are you having difficulty breathing when you walk around the house? Some people get it so bad they have difficulty breathing when they're sitting down in the chair watching TV. That's a bad sign. You should have already been in the hospital. So I'm appealing to people who are at home, at their own home. If you are getting these symptoms, difficulty breathing because of what's happening in your lungs, the adult respiratory distress syndrome becoming manifest in your lungs, plus a community-acquired pneumonia, jumping on board, do not stay home and bear it out. It's not like a common cold. Well, I get a little tightness in my chest and it'll pass. Not this virus. If you get that symptom, please call 811. They will come collect you. They will support you all the way to the hospital, and they will take over the management there. As I said, there is hope. A lot of people who go to HDU, they do come out. If we catch you early, it's a good chance we can assist you to come out of the hospital in one piece, alive.
Thank you.
Thank you. Just want to tag on to that. Again, just emphasizing exactly what Dr. Parkinson said. Any worsening of symptoms, especially fatigue or shortness of breath, shouldn't be taken for granted. Definitely seek care as soon as you notice anything like that. To answer a little more specifically on the long-term symptoms related to COVID-19, the CMOs each do have the ongoing practice of monitoring or staying in contact with individuals who have been cleared, have been released from the immediate acute monitoring, and we are still compiling information on whether people have lingering symptoms. So while we haven't seen that occur very commonly, you may have an anecdotal case here or there. As time wears on, we are compiling more and more evidence or information on what that presentation may look like in our population. So we will get back to you with more information as we collect more data, but we are monitoring. So this information will be made available as it becomes accessible to us.
Thank you, Dr. Hines and Dr. Parkinson. And now TTT, please.
Good morning, everyone. Crystal Wilson, TTT Limited. My question is for Dr. Parkinson. Dr. Parkinson, on the matter of persons with underlying conditions and for those that survive, Can you perhaps share with us what type of lifestyle they are able to lead post their infection? Or is there long-term damage, or are they able to lead pretty much normal lives, but of course cautious ones? Thank you.
Good question.
That's another good question. The jury is still out on that all over the world. But as Dr. Hines was alluding to, there are some anecdotal cases where people do have some respiratory problems. Now, ARDS normally has a high mortality rate in itself. The COVID mortality rate is around the same level as the ARDS. ARDS does have a certain number of people, a very small amount, who when they leave hospital, if they were athletes, they won't be able to perform at that level again. Their lungs may have gotten some scarring in it, and that will decrease its capacity. Okay, now this is few and far between. It's not the norm, all right? It's another thing that doctors were concerned about, especially in the States, in that one of the problems is you get inflammation, as it were, of the heart itself. They don't want to call it myocarditis as such. Myocarditis is when you have inflammation of the muscle itself. They don't want to call it that, but what sports medicine doctors are worried about is that if people who had COVID, they go back out into heavy athletic training, there is a chance they could die of something called sudden death, sudden cardiac death. Heart goes into arrhythmia. Studies are being done on that. We have no answers at this point in time, except that if you're going back, if you have COVID positive, you're COVID positive, and you're going back to do heavy sports, you should consult your doctor and get at least an ECG or echo done on you. Okay?
Thank you, Dr. Parkinson. Newsday, please. We're ready for your questions.
Hi, good morning. Marissa Fraser from the Newsday. So my first question is, I know that initially when we started seeing a high number of cases appearing seemingly overnight, that the ministry had made it clear the results do not represent the results that came in within a 24-hour period. And leaning to that, I want to know how accurate can we now be with the rate of infection, or rather, what is the rate of infection looking at right now? My second question is based on someone who reached out to me. She said she has been swabbed since the 20th of August at the Superior Health Center, and she's not getting any feedback. She's calling the hotline, the CMOH, she's not getting any feedback. She eventually got onto a doctor from the health center who said to come in because she was coughing, and they gave her antibiotics and sent her back home. She's really concerned and wondering what to do. So how should I guide her, or can you guide her?
So I always urge the media, when you have these cases, don't wait for a press conference to raise it. Send it to the ministry and we will investigate it. All we need is the patient's name and phone contact. So I cannot comment on that individual case because we simply don't have the information. But don't sit on it. Send it to the Corpcom as soon as you have it, because time is of the essence and you and I could work together to alleviate that particular patient's fear. All right. Speaking about our rates, we said that when we went into August that the capacity to test was being outstripped by demand. Therefore, we had a backlog. We worked hard. We clawed back that. I can tell you as of today, we only have 630 tests which are now current. So as of today, we are now current with testing and reporting. So by early next week, we will once again be back to our parameter, give or take 24 to 48 hours. It could be less. As a matter of fact, in San Fernando now, it is less than 12 hours because they have their own machine. They have done about 700 plus tests. Many patients are getting test results using the gene experts within 2 hours. But by and large, for the total national program, we only have 630 tests to do today, which is current. So we have clawed that back, and that is a good place to be. But again, just send us the name and contact number of that individual. We will investigate it and make sure she gets the care and attention she deserves. Don't sit on it. Send it to us as soon as you have it. Thank you very much.
Minister, if I may just
Sure.
tag on to the question regarding the accuracy of the rates. This is the exact reason that we then present the additional epidemiologic information where we separate the positives by the date on which they were collected, so you get a better idea of that distribution. So when you look at the number of positives by the date of swabbing, you get that accurate distribution of cases per day. So that's already being provided. That's not actually being impacted by the fact that we do have, or we did have that retrospective batch of cases that we were updating on a given basis. So I just want to assure you that that information is then analyzed on the day-by-day basis to give you that accurate epidemiologic picture.
But I'm glad you raised that issue. Yes, we have 630 cases today. We are now current, but it does not mean it's a license for the population to take advantage of those gains that we have made. We want to keep demand for testing down, because for demand for testing means less persons going to hospital, less persons in ICU, less persons in HDU, less mortality. And again, the words of Dr. Maria Van Kerkhove, it rings so true. What we do now at the personal level, which we have been saying here, will reap tremendous rewards. Thank you very much.
Okay, thank you. We move now to TV6, please.
Hello, Vanessa Cutting, TV6 News.
Morning.
Good morning.
Hi, morning. The Barkeepers and Operators Association, it is asking for some clarification where it concerns the exemption for sports members clubs, given that these establishments would have restaurants and or bar settings within them, and they're alleging that this is discrimination. So they would like some clarification on that. And also, you mentioned a short while ago that the legislation where it concerns public and private space, that is something that would have to be debated in Parliament. Could you then indicate when we could look forward to this happening?
So thank you for the question. So we did indicate that the Attorney General is looking at it. I have no timeline for that. But Renessa, I want to make the point again. Law alone would not solve this. We are asking for people to abide by the spirit of the law. That is, the same way we are saying no more than 5 in public, the spirit of the law is conduct yourself the same way at home. The same way we are saying, wear a mask in public, we are saying if you have a COVID positive patient home, wear your mask in private. We keep saying, and this is not unique to Trinidad and Tobago, the spirit of the law is what will see us through this. I don't think you want the government to be high-handed and tell you what you can and cannot do in your home. So that's one. 2, the issue of clarification. I was on 95.5 yesterday clarifying, and I think I did it earlier this morning. These were requests that came from the president of the Lawn Tennis Association that will govern how non-team contact sports can be conducted on their premises. It's as simple as that, and I don't know how else to clarify the statement, but if further clarification is needed, I will ask the Corp Club and legal to do that.
Okay, thank you. And we seem to have just a little more time, and so we will receive one question from AZP News. One brief question, please, from AZP News.
Hi, good morning again. I just wanted to find out, when a patient is at home, is there any treatment he gets? Is there any specific thing that he would get? Because normally someone at home would be a mild case. So I just wanted to find out what sort of treatment. Thank you.
Thank you. And we move to Dr. Parkinson to just give some feedback on that question, please.
No, there's nothing specific for patients who are at home, just the normal core remedies, as it were. Panadol for fever, drink plenty fluids. If you have your normal diabetic or hypertension medicines, you continue that as normal. Okay, there's no other COVID treatment as such to be given at home.
Thank you. And now 98.1, one question, please.
Thank you again, Ms. Alcantara, and Minister Deyalsingh. Thanks for that information. I will forward the name of the person in question to the Corp Com department. But my question, single question, final question, is directed to Dr. Hines. Dr. Hines, could the human eye, this question was, was put to me, could the human eye be considered an entry point for COVID-19 and so create the same kinds of risk factors?
Okay, thanks for that question. I think it had been covered early in the trending conversation on the virus that all mucous membranes, including the mucous membranes that cover the eye, are potential entry points. Now, this potential entry point was less for viral particles floating around in the air and more for the contamination via dirty hands. Now, the need for the hand hygiene and the regulations around mask wearing would, to a large extent, help to reduce the risk of having any sort of contaminated viral particles reach your eyes one way or the other. And yes, mucous membranes, including the conjunctival membranes, are potential entryways. And yes, we have been providing guidance to the population on how to reduce that risk. So we do hope that all of the guidelines are taken as a whole, as a package, because they do help to cover scenarios such as the one that you're asking about now.
Thank you very much. And so we use this time to just remind everyone about their individual responsibility. We go to the video one more time.
Everyone on the planet needs to know what role they have to play and to be informed about what this virus is, where this virus is circulating, especially in the areas where you live, the areas where you work, the areas that you want to travel in. All of this is important. There's so much that you can do yourself to protect yourself from getting infected and to prevent yourself from passing the virus on to others. And please make good choices. I know that there are a lot of things that we want to be doing right now, but there aren't necessarily a lot of things that we need to be doing right now. There are many people, essential workers, who cannot stay at home. There are many people who are caring for patients in hospitals who cannot stay at home. And if you can, and if you can help, and if you are asked to, please stay home. You can practice physical distancing from others. You can avoid crowded places. You can avoid enclosed settings that have poor ventilation. You can clean your hands. You can practice respiratory etiquette. You can wear a mask if you cannot do physical distancing. Everyone has a role to play. And this is far from over. So we all have to play our part.
Thank you everyone for tuning in to today's media conference. We just want to remind you, please do not risk your health for the sake of convenience. Follow the new normal and wear your mask.